about embryology, prenatal development. This will be a series of 3 lectures. In the first one, we're going to talk about prenatal development. Then in the coming 2 lectures, we will talk about the prenatal, the postnatal development, which basically the growth postnatally. Now, as an orthodontist, why is it important for us to study growth? Why we are concerned about studying facial growth? Let's take this patient as an example. If you have a patient with the class 3, as we can see here, she has a class 3 due to retrognathic maxilla. And if we look at the occlusion, we can see that she has a negative overjet. So if we're going to provide treatment for her, we need to know exactly what is the growth going to be like. So, for example, if the mandible is going to grow more, then this case is going to be more severe. While if the maxilla is going to grow more, that means that the case will be easier and it will solve itself. So prediction of the changes that can happen or the growth changes is something very important in order to provide treatment. The other thing is to utilize this growth for the treatment. So here in this case, again, she has a retrognathic maxilla. If we know exactly when the maxilla growth spurt is, so we can use a growth modification to stimulate the growth of the maxilla and correct the malocclusion. The last one is to time the orthognathic surgery. We all know that if we're going to do an orthognathic surgery, we should do it after the completion of the growth. So, because it doesn't make any sense to do the surgery and then the patient grow more and it get worse again. So we need to know that the growth is finished and then we start the treatment. So we need these insights into the growth of the face in order to provide proper treatment. Also to understand the development of facial anomalies, because we are treating the part of these anomalies by treating the teeth. Before getting into the embryological development, just a quick revision about the chromosomes. Now we know that each chromosome is formed from chromatid. And this chromatid has a short, which is basically these 2 legs, is called chromatid, this one and this one. So both of them will form a chromosome. And then each chromatid is formed from short arm and a long arm. Now the short arm is called P, and that's from petite in French. And then Q is the next letter, so that's why it's called Q. The long arm is called Q. And if you look at this chromatid is formed of DNA, which basically the genes that is forming the human or having the codes for the whole human body. So we just said gene. What do we mean by this word? It's a specific location of the genetic coding that possesses part of the building block of an organism. Now, as we are talking about growth, the most important gene is that one is called homeobox genes. It has the whole blueprint of the growth and development, and any problem and anything affect these genes will result in a growth syndromes. Now, each gene is tailored and designed to have an information required for a particular function, and this gene can be switched on and switched off depending on the demand. Now, any error in the gene itself or the mechanism that controls this gene will result in a syndrome. Now we will start with the embryological development. There is 3 main periods or stages in the development of the embryo. The first one is called the development of the ovum, and that's basically started with the conception and finished by 7 to 8 days from the conception. And I will explain that for you right now. So if you look at here we have the zygote, which basically the zygote formed by when the sperm penetrated the zona pellucida, which is the hard layer outside. The zona pellucida is formed after the penetration of the zygote into the ova, and that's because it will protect it from any more sperms coming in there. And then so now we have the zygote, and then this zygote will start dividing, but the zona pellucida is still there. So this division or this mitosis will keep going, and cells will increase in number, but they will not increase in the size. Okay, we call this cleavage because basically there will be no increase in the number or in the size of the cells. They will keep going like this until the 8th day, in which it will be called morula, which is similar to this kind of fruit. Morula, it's a lot of small circles surrounded with a huge or with a tough or rough surface, which is the zona ballosida. By this, we finish the first period, which is the formation of the ovum, and then the second stage, we call it the embryonic development, which starts by the 2nd week to the 8th week of conception. Now, the 2nd week, which basically we said that the previous stage takes up to 7-8 days. Now, this starts from the day number 7. This stage is divided or subdivided into the pre-somite period, and this one starts by the 8th day and finish by the 20th day. And the main feature of this stage that the primary germ layers are formed at that stage. So what happened exactly is that now the morula is formed, right? And then the cell will keep dividing. Now the zona ballosida start to disappear, and the cells will start to differentiate the cells inside it. And we're going to have trophoblast and embryoblast. Now we have two types of cells, and now the zona ballosida start to disappear, and then the trophoblast and the embryoblast will start to differentiate into inner cell mass and the blastocele, which is a cavity that is developed. So again, now the cells are differentiated into trophoblast and embryoblast. Then the trophoblast will stay where they are, but then the embryoblast will differentiate into, or they will start to actually collect themselves on one side and differentiate into an inner cell mass. And then we're going to have a cavity, we call it the blastocele, and then further divisions that will result in and differentiation in the formation of a new cavity called the amniotic cavity. And then now the inner cell mass will differentiate into epiblast and hypoblast. So we have the inner cell that will differentiate it into the inner epiblast and hypoblast. So the start will be the trophoblast and the embryoblast. Embryoblast will differentiate into inner cell mass. Then the inner cell mass will differentiate into hypoblast and epiblast. Now, this one will look like exactly like a watermelon. So the cells are a mass of cells. It's a three-dimensional object. And if I cut a slice through this watermelon, like we see here in this paragraph, and you have a cross section into that one, we're going to see that we have a bilaminar disc. It's formed of two layers, the epiblast and the hypoblast, which are now differentiated into being an ectoderm and endoderm. Then, in the ectoderm, we're going to start to have a proliferation, differentiation of a small knot here that we call it the primitive streak, that later will start to invade the underneath ectoderm. So that would be the ectodermal cells will differentiate to the primitive streak, and that primitive streak will go down between the two layers, forming the third layer, which is called the mesoderm. So now we have the three main germ layers that will give rise to all the components or all the organs in the body: ectoderm, mesoderm, and the last one is endoderm. Now, as we said, the mesoderm is the last one to develop at the week of the 3rd week of conception, and it's usually the result of the ectodermal cell proliferation. As a dentist, we need to know that the oral mucosa and the enamel are driven from the ectoderm, while the bone, muscles, connective tissue, pulp, dentine, periodontal ligament, and cementum of the teeth are driven from the mesoderm. Then we have the somite period. So it was the pre-somite period. Now we have the somite period, and that extends from the 21st day into the 31st day. It's a small 10 days, but these 10 days are having a lot of divisions and organ establishment. Then we have the post-somite period that will extend from the 1st to the 4th to the 8th week of pregnancy. During that, there will have a rapid growth of the organs, which is already established in the somite period. The main feature from this one is that the external form is already established of the body, and the head is dominated the whole development and the whole size. So mainly the head is the main size and the main development in that stage. And at the end of this stage, now the embryo is no more called embryo, we call it fetus at the end of the 8th week. So that's what's gonna happen exactly. Again, we have this bilaminar layer. They will start to differentiate, but then we're gonna have something called neurulation. So here in the mesoderm, we're gonna have something we call it notochord. Notochord, this one will start to develop, and that one will stimulate some sort of development to happen in the ectoderm. The cells will start to differentiate, and here we're gonna have something that we call it the neural plate. Further differentiation of this neural plate cells, they will invade the mesoderm, and by one, this neural plate will become a neural tube. It will look like a tube exactly, going from all the distance in the mesoderm. It's called the neural tube. And this neural tube, remember, is going to come back later when we talk about the development of the forebrain, midbrain, and hindbrain. And then the neural tube cells, it's not a perfect process, the formation of it. So we're going to have a lot of cells moving out or shedding out from this neural tube, invading different places in the mesoderm. These cells is called the neural crystals. However, even though they are formed in this way, they are very important and they originate multiple organs, to the point that some embryologists call it the neural crystals as the 4th germ layer. So that was all for the embryological development. Now, after we finish this stage, we move to the 3rd one, which is the fetal period, which basically from the 3rd month until birth. And this one, there's no organogenesis or differentiated in this stage. It's only multiplication of the cells and increasing in the size. For that reason, the first 3 months of pregnancy is the most sensitive period and the most sensitive time of pregnancy, because any radiation exposure, any stress might affect the organogenesis stage that happened in the first 3 months. So now the cells are dividing, so the embryo is going to look something like this. And now in the face particularly, the face has to be divided into right side and left side. And here there's a thickening of the ectoderm, forming something we call it the precaudal plate. And this one will act to divide as a face. We have right eye, left eye, and right cheek, left cheek, and so on. And this precaudal plate will play a major role in signaling and the guiding and organizing the further division and subdivision of the cells. Now we'll have segmentation of the neural tube. As we said earlier, the neural tube is here going through the mesoderm. Then this neural tube will start to have differentiation and segmentation, and you're going to have the forebrain, midbrain, and the hindbrain. That is the 3 parts. And we're going to have here in the top what we call it the frontonasal process that will start to develop in this area. Now, the frontonasal process will give rise to later on to the nose and the upper lip and the primary palate. And then we're going to have as well differentiation of the fetus, that we're going to have 6 pharyngeal arches, and these we're going to give structure to give rise to the most of the structure in the head and neck area. So now after the division of the cells, the embryo going to look like this with the forebrain, midbrain, hindbrain, and we're going to have the frontonasal process and the pharyngeal arches. To help you understand this, that's the embryo, how it's going to look like during that period. And here the area in which we're going to have the pharyngeal arches. So in this area here, that will be the frontonasal process, and here in this area the forebrain, hindbrain, and midbrain. And here they're going to start the development of the pharyngeal arches. So here we have the pharyngeal arches, Okay, they start, as you can see, differentiation and division until we're gonna have 6 pharyngeal arches. Now if we're gonna go and get some like a straight cut like this and see what's going on, you're gonna see the appearance, how it's gonna look like. So these are the pharyngeal arches, and as I said, here we do the cut. So you're gonna do this cut to see the type of the cells that we're having is gonna look like this. At that time here we have the ectoderm from outside, endoderm from inside, and mesoderm from inside. So this is from outside, this is from inside, and between them is called mesoderm. Now each pharyngeal arch gonna give rise to different structure. For example, the first pharyngeal arch will differentiate into 2 arches, the maxillary arch and the mandibular arch, which is going to give rise to the maxilla and the mandible and different structure, while the second pharyngeal arch will give rise to the suprahyoid structure. Third pharyngeal arch is going to give rise to the infrahyoid structure. Now if you look at this at the pharyngeal arches, this structure like this is called pharyngeal arch. The lining of the pharyngeal arch from outside is called ectoderm, inside endoderm, and in the middle is called mesoderm. Now this one from here to here, it's gonna have like a narrowing or necking. We call it from outside pharyngeally cleft, while from inside it's called pharyngeal pouch. That's how we name the pharyngeal arches. Now the first pharyngeal arch, as we said, it produces the jaws and dentition, while the second pharyngeal arch would produce the suprahyoid apparatus of the neck, while the third pharyngeal arch contribute to the infrahyoid region, while the fourth and the sixth pharyngeal arches form the laryngeal structure. So what about the fifth pharyngeal arch? Well, the fifth pharyngeal arch in a human being is rudimentary, and that will degenerate after the formation. So it will be formed, will do nothing, and then it will degenerate. So we have 6 pharyngeal arches, but only 5 of them are working. Now this is kind of help you to understand it. So here is the frontal nasal process, and then we have the pharyngeal arches, we have the maxillary process, we have the mandibular process, and then we have the rest of the pharyngeal process. Now don't get confused. In some textbook you're gonna find that the author called them the branchial arches as the pharyngeal arches. This is interchangeable, so don't worry about that. Now the pharyngeal apparatus consists of arches, as we said, separated by pouches, grooves, and membrane. And the last thing, as we mentioned, that the fifth pharyngeal arch is rudimentary, and we will not have any organ coming out or develop from the fifth pharyngeal arches. So what's going to happen if we have an abnormal development of the pharyngeal arches? Then the answer is, it depends how much damage is that happen in the development or in the genes that is controlling the stage. The more damage or the more genetic error that we have, the more symptoms we have. So the first one is called the Treacher-Collins syndrome. Basically, we're going to have a defect in the first arch. So basically, any structure driven from the first arch will have an issue. The first one is external ears. Will be malformed or sometimes absent. So the patient definitely going to have a hearing problem, hear loss. The jaws as well will be affected because we know that it's formed from the first branchial arch. So we're going to have a hypoplasia of the facial bone, especially the mandible and the zygoma, and we're definitely going to have a cleft palate. The second one is called the Pierre-Robin syndrome, which basically defect in the first arch as well, but to a lesser extent or a different extent. This one is called triology. Triology means that 3 symptoms come together, which is micrognathia, which means that the mandible is too small. Then macroglossia, that the tongue is big, and because of that, now some say this is the theory, they're going to have a cleft palate because simply the mandible is retrognathic, the tongue is big, so all what you need to do is to squeeze the tongue and push it upward. That will prevent the closure of the palatine shelf, as we're going to see later, and result in a cleft palate. So now we're going to talk about the development of the face, development of the skull, development of maxilla, and development of the mandible. So we're going to start with the development of the face. Development of the face starts by the 4th week. At that stage, the embryo going to look like this. And here is the fronto-nasal process going all the way down. The green one here is called the maxillary process, which is a branch from the first branchial arch or the first pharyngeal arch. And then we have the mandibular process, and again, this is a branch from the first pharyngeal arch. And then we have the nasal placode, which basically later in the future will differentiate an olfactory sensory system that will be used for smelling later on. So we have this by the age of 4 weeks. Then further divisions, further differentiation of the cells. The frontonasal process now at the 5th week will differentiate into 2 processes. The first one is called the lateral nasal process, and the second one, or the inner side one, it's called the median nasal process. So we either have lateral nasal process or median nasal process. And we have only mandibular process, and then we're going to have right maxillary process and left maxillary process, and we have the nasal pit now because it's surrounded by the fronto nasal process, which is the median nasal process, and the lateral nasal process is called the nasal pit. Now during the 6th week and the 7th week, growth again continues from the median nasal process and the lateral nasal process and the maxillary process. So this growth from the median nasal process, it will push the lateral nasal process upward and away, and it allows the medial nasal process to fuse and to meet with the maxillary process. And here we get the central part of the nose, and we get the lips and the primary palate. So failure of fusion between the median nasal process and the maxillary process at this area will result in the cleft lip. So failure of fusion again between the medial nasal process and the maxillary process will result in a cleft lip. So later on, further differentiation and further differentiation. Now they will have a fusion between the lateral nasal process as well and the maxillary process, and here we're going to have the nasolacrimal duct formation, the cheeks, and the alar base of the nose. So that was all the development of the face. And as we mentioned, if failure of fusion between the maxillary median nasal process and the maxillary process happens, so if we have a failure of fusion, that means cleft lip. Then what about the palatal development? The palate development usually starts by the week 6 and finish by the week 10. So during the week 6 and 7, this is kind of a sagittal cut, in which we are looking, or sorry, coronal cut, in which as if you cut the face, the head in half, and you are looking from behind. So this is, we call it the nasal septum, which is the nose thing. And as you can see, the oral cavity and the nasal cavity are all connected in a very big cavity. And the tongue is sitting between the 2 shelves of the palatine. And by the way, these palatine shelves are driven from the maxillary process that is already driven from the first pharyngeal arches. So the first pharyngeal arch will give rise to maxillary process, which will give rise to the palatine process. Now, for the fusion to happen between these 2 shelves, the palatine shelves has to do elevation. They have to move up and then fusion, because the tongue is preventing them from doing so. So in any syndromes in which they have a macroglossia or increase in the size of the tongue, there will always be a risk of developing a cleft palate. So what's going to happen first, during the 7th to 8th week, we're going to have elevation. We call it elevation of the palatine shaft, in which the palatine shaft will elevate above the tongue, and then they're going to have fusion between the palatine shaft on the right and left. Now, failure of fusion will result in a cleft palate, and more common now, failure of elevation. and that the shelves are trapped near the tongue, and they can't do any form of elevation. So far we talked about the development of the palate, development of the face, nose, maxilla. Now we need to talk about the development of the tongue. The tongue arises from a series of swelling. It appear around the 6th week of the development of the floor of what we call it the primitive pharynx. So basically this is a photograph of, or like diagram, at the age of 5 weeks, while this one at the age of 5 months. Here you can see the different germ layers. First, we have a lateral lingual swelling from the first pharyngeal arches. That will result differentiate in something we call it tubercular impar. Okay, that one, and we have that basically in the future will form the anterior 2/3 of the tongue. Okay. And then we're going to have a differentiation and growth from the 2nd, 3rd, and 4th pharyngeal arches that will result in the formation of the base of the tongue, or the other third of the tongue. The 4th pharyngeal arch as well will continue in differentiation to develop the epiglottis. So that was the development of the tongue. Now then we're going to talk about the development of the skull. So how the skull is developed. First, we need to know the definition of the division, how we divide or how we classify skulls. We classify skulls into two parts. We call it the neurocranium and the viscerocranium. The viscerocranium is the one that you can see that it represents the face of the patient, while the neurocranium is the one that is surrounding the brain. So viscerocranium is the one that the face, basically the one that the patient face in the mirror, while the neurocranium is the posterior one that is surrounding the brain of the patient. So start with the neurocranium. The neurocranium is further subdivided into two types. The cranial vault, which is basically the one that is surrounding the brain, and this one is developed in membrane, and they are surrounding the brain. The other technique is to use the other division is the cranial base. So we have the cranial vault and we have the cranial base. Now the cranial base is called chondrocranium as well, because it's developed from cartilage template and form the base of the skull. We call this endochondral ossification. Now, with the exception of the clavicle, all the bone of the intramembranous ossification, they are found in the skull. Collectively, the intramembranous ossification and endochondrous ossification are originated from the cranial neural crest cells and the paraaxial mesoderm. So that's the definition. Later we're going to cover it with the paraaxial mesoderm. Now these bones begin to appear during the 5th week of development, and by around 7 months ossification has progressed to the extent that they meet each other at what we call it sutures. So basically the growth of the skull, or the growth of the intramembranous bone, this is the cranial vault, will keep going and continue from the 5th week up to the 7th month of the treatment. By that time, we're going to have a contact between these bones in a form of sutures. Now then, that's to still about talking about skull. We have the viscerocranium, and this is basically the facial skeleton, the face of the patient. And usually this one is developed from the neural crest cells, and that's migrated into the 1st and 2nd pharyngeal arches. Now, in the maxilla, ossification, as we're talking about the skull, is seen in the region of the primary canine. In the mandible, we have an ossification just medial to the Meckel's cartilage. And here we need to talk about Meckel's cartilage. It's called fate of Meckel's cartilage. Now, when the scientists looked at the embryo, they found a replica of the jaw of the mandible made from cartilage. So we thought, or the scientists thought, that this Meckel's cartilage is the origin of the mandible, because it looks like a mandible. It's made of cartilage. Mandible is endochondral ossification. However, all the research has shown that the bulk of the Meckel's cartilage will resorb during the process of ossification, and the ossification will start just medial to the place of the Meckel's cartilage, and the Meckel's cartilage will not contribute to the mandible except that we're going to have 4 places in which we're going to still have cartilage. The first one is the lingula of the mandible, then the first 2 ossicles of the middle ear, which is malleus and incus, and then we're going to have the anterior molar ligament and the sphenomandibular ligament. These are all points that is originated from Meckel's cartilage. And here it comes to the question, what is the difference between the primary cartilage and the secondary cartilage? Now, the secondary cartilage it's called that because it's appear after the primary cartilage skeleton has been found or formed or created within the embryo. So the first kind of, let's say, replica or blueprint of the patient from cartilage is made. After a while, a new cartilage come up. We call this new cartilage as a secondary cartilage. Now, during the development of the mandible, we will have a 3 secondary cartilage at around 10 weeks of the development: the condylar cartilage, the coronoid cartilage, and the symphysial cartilage. Now, the coronoid cartilage and the symphysial cartilage usually transient, and will disappear during the first year. Usually the symphysial one will stay for 1 year, while the coronoid process will close even before birth. And we have for sure the condylar cartilage, which lasts until the age of 20, the longest of all of them. So what's going to happen with the condylar cartilage? So first, calcification and ossification of the cartilage start in an area far away from the patient who's provided with treatment. At the beginning, which basically at the 5 months of treatment, the cartilage is huge. It's a huge amount. But then what's going to happen that this cartilage will resorb, and there will be a bone formation in the place of the bone resorption. The cartilage resorption. So the condyle cartilage will continue to postnatal mandibular length until the teens. So what's going to happen? We're going to have the cartilage here. It started in an area separate or far away from A. Then this cartilage keep going as well, increase in size. But later, when the patient is 20, this cartilage will reduce in size to a small band that is responsible for a lot of growth activity. Then we have cartilage on the coronoid process, and we know that this one will close even before birth, while the symphysial cartilage will unite the 2 halves after 1 year. However, during this 1 year, the symphysial cartilage will close and fuse together. Thank you very much for listening.